Φίλοι μου, καλησπέρα.
Καλησπέρα.
Ελπίζω να είστε καλά και να έχετε επιβιώσει με αυτή τη ζέστη.
Όχι, σήμερα δρόσησε.
Σήμερα δρόσησε, ναι. Σήμερα είμαστε χαλαρά. Και επειδή χαλαρώνει και αρχίζει και ζεσταίνει όμως, είναι καλοκαίρι και αυτά, και είπαμε λίγο να το γυρίσουμε και στην ορθοδοντική. Σήμερα έχουμε έναν εξαιρετικό ξένο ομιλητή, τον Νικολά Νάσμ, ο οποίος θα μας μιλήσει για aligners και για ορθοδοντική. Dear Nicholas, thank you very much for being here with us. It's a great pleasure to have you here. I give you the microphone. Thank you very much.
Thank you a lot for introducing me. Hope that it's not very late, but I understand that 9:30 in Greece, it's still at the start of the evening. I'm here to introduce a new concept with lots of ideas. Hopefully that you will find this extremely interesting, with lots of tips and clinical tips, of course. So starting very fast, my name is Dr. Nicholas Najm. I am an orthodontist in France. My clinic is not very far from Charles de Gaulle, which is like 15 minutes from the airport. I always say this, and I have lots of people that come to my clinic in order to see how the organization stuff, how things are going on with respect to aligners. I'm a super fan of aligners since 2009, and I have used lots of aligners all over the way. And today I'm using this system. I will show you a little bit. What does it mean? Why, etc., etc. I will not. But at the same time, I will give as much as I can, like tips and then tricks and clinical focus. Of course, if you want to come to see me, you can always send me an SMS. By the end of the webinar, I will send you my coordinates so that you can eventually contact me, and then you can spend a day gracefully, of course, and so that you can understand a bit more. And of course, you will learn lots of things, because I do this all the time, Every 3-4 months, I just try to go to a clinic which is a little bit different. If it is something that I don't know, I want to learn everyone's world, and I really learn lots of things clinically speaking, So you are very welcome, and it's my great pleasure to welcome you in my clinic if you'd like to. Every time I always mention my team, and of course these are the colors of France. If I'm here, it's of course because of them. I will pass a small video, and I think that you're not hearing the voice, but anyways, I will try to explain a little bit. It's not a factory. It's not a lab. Sorry, it's not a lab. It's a factory. So it's a small process that you can see, where everything is made 100% with respect to the norms of a big factory. So you cannot have quality aligners if you're using a Biostar, because the pressure of the Biostar is like maximum 4 megapascals. When you have a pressure with a big machine, it's 12 megapascals. You cannot cut aligners by hand, because it's not the standard that we are searching for today in order to have good quality aligners with respect to our patients. So we cannot have things if you have labs and stuff like this. So it's a factory, and everything is made in France. I will show this a little bit later. So one of the biggest points is that you look at the first photo on the upper part of the screen, and you see lots of attachments. And then you say, oh my God, this is what I have promised my patient. I have promised my patient to give him an invisible treatment. And all of a sudden, I have all these attachments everywhere. And we dig deeper inside this story with this configuration, and we understand eventually that these attachments are made automatically by the software. And then when the software automatically decides by itself, without the consultation of the doctor, that these attachments have to be put this and this and this there, we have also recognized, and then we digging deeper inside the process of these attachments, that these attachments, okay, they are put by the software, but at the same time, thresholds of having these attachments on teeth is so low that I will have an attachment for 3 degrees of tip on the 7. I will have an attachment for 5 degrees of torque on the 5. And so eventually, when I have these all attachments, I will end up with this photo which is similar to the upper photo, and this is not something that I have promised my patient. How many times you have seen this? And I have seen this in my clinic how many times the patients come to you and say, really, this is what you have asked me, or you have promised me. I would have rather preferred braces instead of aligners, because braces, at least, they don't change the color with time. These are things that will change the color because the bonding and the quality of the composite, etc., etc. The first idea was, okay, fine. So we have this system that has to be invisible. So why not trying to have this system as invisible as we can? Of course, replacing attachments by trigger points, we call them advanced dynamic trigger points. It's not very, I mean, you cannot replace everything, but I can replace the attachment of tip by trigger points. So these are small pressure points inside the aligner system, not only for intrusion and torque. These are trigger points on the aligner system in the 3 dimensions of space. Now I have a tooth. Not only I have a tooth and the pressure point, I mean, and the bracket on the buccal on the lingual, I have a tooth where I have plastic all over, what I call like 5 places where the plastic touches the tooth. So now, instead of having only the 5 places where the plastic touches the tooth, and then I have much better control, I can also add these pressure points or the trigger points on the buccal, on the lingual, on the occlusal, and even on the distal and the mesial, so that I can have much more control. Okay, I'm not only having these pressure points on the palatal, on the lingual, and only in the buccal. No, I have these pressure points everywhere, so that I can push this tooth in 3-dimensional space and have much, much better control. And we have divided this into 2 parts, two kinds of pressure points, or we call them trigger points. The first one is active, so one is pushing all the time, and then the one that is passive. So passive, for example, if I want to intrude the lower incisors, instead of putting attachments on the 4s and the 5s in order to hold up the posterior teeth, and then I will intrude them with the plastic and the attachments to the posterior teeth, they will hold the counteractive part of the intrusion-extrusion dynamics. Now I will have passive attachments in the interproximal areas, so I will have different kinds of trigger points. This way, in the interproximal areas, I will have retention areas, and then when I'm intruding anteriorly, I can replace that posterior attachments by these trigger points, which are passive. These are passive, then the active ones are really pushing the teeth every time. These are small examples where I want to make translation, for example. So I will take this tooth and then I will push it in this way on the mesial and distal. You know, aligners, by the way, these are one of the most important. These are one of the tools the tools that we can push teeth with the mesial and distal. These are almost the only tool. The aligner is almost the only tool where you can move the teeth, taking into consideration that you have a force that can grab it from the mesial on the distal, and then you could do whatever you want. So you can see these pressure points everywhere. Of course, they are super transparent. They are very aesthetic, and most of all, they're much more predictable. And they have this aligner system, force system, which would be when you apply it on 3 dimensions of space, it will have excellent results. And I will show you lots of cases. And you can see how the aligner is super beautiful. It's very transparent. You do not have these lines. And I will not talk about the quality of the plastic of this brand. At the same time, you can see it will not go, because when you have lots of lines, of course, you can have lots of retention of all the coloration of the elements that the patient is eating every day. So the quality of the aligner will degrade with time. Now, one of the things that we have also tried to treat differently is, and you will see lots of things and with this webinar, is how we treat the lateral incisors. Okay, how we deal with lateral incisors. Of course, the lateral incisors is a big deal for everyone, and they have a super bad reputation. Without going into details why and what's happening with the lateral incisor, just to give you a quick overview, when you have a small lateral incisor, when I'm talking about small lateral incisor mesial-distally, the moment of force when you want to rotate it, for example, like your mesial in the lateral incisor is small. Why? Because the distance between the center of resistance and the distal part or the mesial part of the tool is not very wide. Eventually, the force, which is with the moment of the force, which is the force and times the distance, is because it's the lateral incisor is not very wide, it would be not very huge. It would be a small moment of force. And when you have a small moment of force, then the rotation of the mesial in or distal out of this tooth, it will be much more difficult. So, of course, everyone has this. People who do aligners, as me and you today, we all have this kind of problem that the lateral incisor does not track. Okay, so what you try to do is that to apply this principle of the pressure points on the lateral incisor in such a way to control much better the 3 dimensions of moving this lateral incisor. I'll give an example and try to adapt what I'm trying to say at the same time so they can understand why it works better when you have these kinds of pressure points. This is a patient where you can see these photos in class 1 from both sides. That's a very minute, like an overbite, and then you can see lateral incisor, extremely typical. Central 11 is lingually, tipped lingually, and the 12 is tipped buccally, and at the same time, of course, it has this root distal tip and the mesial round crown tip. So this is extremely typical, and this, when you want to treat it with aligners, you really have to focus on this, because if you have to treat it with braces, it's easy. When you have to treat it with aligners, you have to be very, very skeptical, and you have to look what's happening with lateral incisors. Otherwise, if you're any kind of system, any kind of these big systems, you just the data are aligned, but it doesn't mean that it will work. And if it doesn't work, what will happen is that you will have to find 1 refinement, 2 refinements, 3 refinements, and then eventually for the patient, he will truly lose trust in you and the system, and then after all, the lateral incisor will not be aligned, and you will have what we call a failure. Okay, so looking at this in another way, this is a very minute class 2 from the other side. You can see the occlusal view of this tooth. How is it? It is, well, yes, of course, minor crown on the lower side, not something extremely difficult by the sense of the difficulty of the case. But what I wanted to emphasize is that how we control this lateral incisor with these pressure points. So now I will show you the result, but at the same time, I will show you. You can see 0 attachments, right? Okay, 0 attachments on the anterior teeth. This is what we try to do. The system is made to minimize the attachments on the anteriors. Of course, we have some attachment on the posteriors. We have attachment on the lower teeth. Yes, okay, fine. But at the same time, we will try to minimize as much as we can the attachments on the we put attachment on the posteriors on the lower side because we have made translation premolars, and translation needs buccal torque on the lower with the expansion. So that's why. But anyways, you can see we will not have hundreds of attachments, especially on the anteriors. Okay, but what we did in here is eventually we pushed the lateral incisor a little bit outside. Okay, and then when we pushed it a little bit outside, then we applied the trigger points on the mesial. So the mesial side was already, you can see this, you can see in the photo. The mesial side was a little bit outside the arch and at the same time tipped. So what we did is that we pushed the distal side a little bit on the outside. We had grabbing effect in the mesial and distal. We applied the pressure point. Once we applied the pressure point, we tipped the tooth, and then when it is tipped, then we brought it back the arch without having the necessity to bring an attachment on. Now, there are lots of problems with attachments. I will explain a little bit later. Okay, we have only 1 hour tonight, but you can see the efficiency of these pressure points without any kind of attachments on the lateral incisor. One of the things that we do is that we try to control as much. This is like one shot. What we call one shot in Bloom is that one treatment, one set of aligners, one result. We don't need any kind of refinements. You can see the efficiency of the system, 0 attachments, just with the pressure points on the lateral incisor. Okay, of course, the expansion, the torque on the posteriors, no posterior open, posterior, no posterior gummy smile, the smile arch, etc., and the alignment of the teeth. Another thing is the tip. Okay, now dealing as well with the lateral incisor, if it's the upper or the lower, whatever, okay, it's always a difficulty with respect to adding any kind of system, because when you have a tooth, when you have 13 and you want to tip the tooth, what you will do is that you will add an attachment. Why? Because you will have a system of force that will tip the tooth like this. Okay. Now, what they have done is that they have cut the middle of the attachment so that you can still have the pressure, the execution power, which is the application of the pressure for the pressure areas or the force system on the tooth, but it would be more aesthetic. Now, when you have small attachments, of course, we all know that when you have smaller ones, that means it is less less. I mean, what you have to be very, very accurate. Knowing that if you have 0.5 millimeter of flash or excess on one of the attachments, then the aligner will not adapt 100% on the surface of the tooth. And when you have not adaptation, then you will have a gap, and this gap will have less control. When you have less control and you have, and with time, then it's like the slot of the bracket and the wire, then you will not have this kind of maximum adaptability of this line of the tooth, and you will have less predictable results, which leads to a refinement and another refinement, etc. Okay, so instead of having all this, I will show this in an example. You have 42, it is extruded, it is on the buckle, so I will not align it by starting it. I would ask the software to have pressure points on the mesial and the distal of the tooth first. I will tip it, then when it's tipped, then I will work on the root tip. I will distal root tip it, and then I will bring it back bilingual. So this is a treatment where we had only attachment on the 6s, not on the 11, nor on the 42. Expansion, tip without attachments, then with the pressure points, and then bring it back and the lines. This is how it starts. You can see on the panoramic, the 42, how it's tipped the mesial, a little bit hyperdivergent with a small open bite on the tears. So we expanded, and that's exactly what I did, so that we can have the result, the expected result, without zero refinements, just with these pressure points, putting pressure points wherever we want to on every kind of surface of the tooth. So you can imagine this kind of, I can put it here and here, there and there. I can put it active and passive. I can hold and push. I can push by two sides. I can just hold by one side and push from the other side, etc., etc. Okay, this is the before and afters. Simple case, of course, but at the same time, I just want you to acknowledge the biomechanics of the plastic that we have already been taught by other systems. Now we changed this, but in a more predictable way. And you can see, sorry, if you can see 42 here, how it became just uprightened by the pressure point. Now we can use this also in lots of clinical cases, okay? As long as if I have an extraction case, I just want to push the 13 back to the posterior. Okay, of course, when you have to push it with just plastic, the center of resistance is very far away, so you will have ground tipping, and you will have the bowing effect and all these kind of things that we don't want to have in an orthodontic treatment. So what we do is that just push it first, apply the pressure points, then move that root back to distal, the apex back to distal, because I have applied the pressure points, the trigger points on the mesial and the distal. Once it is on the distal part, then I will just push back the crown, and then I will close the space. Okay, simple things, very efficient things, but you can find this applicability in lots of clinical cases. Another case, I want to open the space for a lateral for an implant, for the 12, which is a missing 12, for instance. Push it like this, apply the pressure points. Of course, this is what will happen if we do not apply the pressure points. So if I'm come back, I'm here, I'm going like this, and I will continue to push by the plastic on the crown. What will happen is eventually the crown will go distal, but the root will go mesial. Okay, it's the same thing like brackets. I'll push on the crown goes distal. So this is what we should not do. What we should do is this: push it like this, apply the pressure points, trigger points, move the apex distal, and then push the crown to this side. Okay, this is another example. I will show how it works. Okay, you can see the lateral side which is missing 12, right? All right, okay, cross bite on the 42. Okay, this is missing 22. So what will happen is that there's a space here. We'll distalize the 23 in the place of 22, but of course we have to be very careful with respect to the root and the apex of the 23. So push it, and then push, as I said before, with the pressure point. You have to displace the root and the apex in the bone to the distal and then the crown. So you can see this is not, it's a very easy case. Someone who doesn't know to do aligners today is very beginner. He can do these cases very, very easily. You can see the, sorry, so this is the 21 and the 23. 22 is missing. So we will distalize and we'll open the space for the implant without any kind of conflict, without any kind of difficulty. Okay, so we will have the coronal distances ready and the apex as well. Okay. This is before and afters, and this is before and after with the parallelism of the roots, of course, and then the implant is ready to be done by the end of the treatment. Now, so now this is one of the major things that this system has, of course, the trigger points. Another thing which is very, very important, and try to stay on me on this because this is super interesting to understand the mechanism of how the aligners work. Okay, I will start. It's the space management. Okay, people who do lots of aligners, they don't understand me, but at the same time, I want you to understand how important, how critical it is to find spaces. Because when you have an arch and you want to align teeth and you have brackets and braces, just put an arch. And depending, of course, on the form of the arch, primarily speaking, then the teeth will move accordingly. So if I have a wide arch, like type Damon or whatever, or the teeth will go more or less with the form of the arch. Okay, but when we don't have space, because there's lots of pride, and what happens is that when we don't have lots of spaces, then the teeth will go, and you put in brackets and the wire system, then the teeth will go to the path of what we call the least resistance. That means they will go to the place where there's least resistance, which is very, very logical. In a bracket wire system, when there's no resistance, the teeth will go buccally. So you will lose the anchorage and you will have the proclination of the upper or lower anteriors. So they will go buccally because where there is less resistance in the buccal. Now, knowing back the aligners, the system is completely different. When you have an aligner, the system is like a box, and this box is closed on every side of the box. So it's closed on the distal because the aligner is blocked on the distal, it's closed on the buccal, it's closed on the occlusal, and it's closed on the lingual. Okay, it's an aligner. So it's like a box of sardines, you know, you can put two sardines. You cannot put two sardines and a half. Otherwise, you have to cup the sardines and then you put them. Okay, this doesn't work. So the spacing, the spaces, the crowding, the space management of an aligner, of the teeth in an aligner, management control is completely different than the braces, because the teeth will go, when you have braces, a little bit on the expansion, they will distalize a little bit, it will derotate if the brackets are put into some way or another, and they will go to the buccal. In the aligner, because everything is closed, then the path of least resistance is not on the buccal, it's not on the lingual, it's not on the occlusal, it's on the intrusion. So when there is no places, the thing is that two things will happen. The first thing, when you want to align teeth and you have no places, first thing is that the teeth will collide, they don't move. If they don't move, then if the collisions are not very, very strong, they will stay there. And if they stay there, they will not move. That's why when you do a set of aligners and you do not pay attention to do the exact amount of stripping or the software that you're using, that's why the homemade aligners, I've really criticized them very, very strongly because the softwares are not at all evolved. Like using Onyx, for all the respect, of course, and all these kind of systems are very, very old-fashioned. You cannot depend on a software where 0.2 millimeters is critical for my aligner, for my treatment plan or for my treatment results. Anyway, so if I am putting an aligner and then there's no spaces, two things may happen. If the collisions are not very strong, the tooth will not move. That will automatically allow you to do another refinement. And seriously speaking, I mean, more like another kind of thing is if they don't move, okay, it's not the end of the world, just do a refinement, finish. But if you have lots of collisions and the teeth are not moving at all, then the other thing is that they will intrude. And you have seen this if you do some aligners with any kind of system, the lateral incisor will go up, it will intrude, and of course the lower lateral incisor or the central, it will intrude. Now, when it intrudes in braces, it's not a big deal. In aligners, it will become a big deal. And then you cannot finish something. You can finish an aligner treatment with the second molar not 100% rotated. You cannot finish that treatment for an adult with a lateral incisors 1 millimeter more intruded, right? It's a science of 1 millimeter. So you cannot accept this because it's not acceptable neither for us nor for our patients. That's why the management of the space in aligners is very important. I will show this video to make you understand a little bit more, and I will show you the solution for this. So this is a lateral incisor, talking about lateral incisors, or any kind of tooth which doesn't have space. So I want to push this tooth in the spacing that I have knowledge for this, but at the same time, I cannot find so much space because I cannot procline, I cannot distalize, I cannot intrude, I cannot expand for lots of reasons. But the clinical case imposes this on me. So what I shall do, what I would have done, is that either I will strip, so I will cut these scars from the mesial of this one and the other one, or I will just push these scars away from the space so that the lateral incisor will have completely the space to be parked, to be placed in its right position without any kind of collisions. Collisions are a very important word. It's a very important one, the other word. So because the teeth will go where they have space. When they touch too much, as I told you before, this is a problem. Now, you can see the software where you have lots of pressure points that I have already talked about. Okay, you can see them on the buccal, you can see them on the... But at the same time, when you see this video, you have something that you have never seen before. In any kind of aligner system in the world, okay, this is not, I have never seen this. I don't think that exists. It only exists with Bloom. And what does it mean? You can see all the spaces, all these numbers changing in every step. Okay, so I play the video, and in every step of aligner, there will be these spaces that are appearing and disappearing. They are increasing or decreasing. What this means is that in every step will see visually how much in 0.0 millimeters there's spaces in between teeth when teeth are being moved. So if I have a lateral incisor which is blocked in the palatal and I want to push it to the buccal so that I want to align it, and there's no enough space, I would know in a very, very accurate manner with these numbers in front of me when I want to see the setup, the file, a 3D setup, whether this tooth is colliding with the adjacent teeth or not. Because as I have explained, I've just explained, if it's colliding, then it will not move or it will intrude. In order to avoid this, I have to be sure, either I will talk to my technician, but if I talk to my technician will not, he's a human being. You cannot see all these contact points in between all these teeth in the upper and the lower arch. What I can see here is the exact space in 0.0 millimeters all through the alignment protocol. And if in one reason, I saw the lateral incisor, which is blocked in the palatal, but it's moving up to the buccal. It touches a little bit the adjacent teeth. Then either I will have put a note and then I will put this in my clinical notes and then I will just pass by a stripping sheet just to make this passage of this tooth easier. Or I will tell my technician, no, listen, when this tooth comes out and it's being aligned, I don't want to have any kind of control. I don't want to have any kind of collision between it and the adjacent teeth. This way, I will be assured that this tooth, which is coming back, and then it's aligned with the adjacent teeth, it will be aligned completely perfectly without any collisions, without any kind of problems. Okay, this is extremely important in my point of view to have much more control, much more predictability, and much less refinements. Okay, refinements in another word, it's a real problem for us because you cannot today promise our patients to finish in 1 year and then finish in 2. Okay, this for them it's a complete mess, and you will lose complete confidence and complete compliance after the 1 year. Okay. This is the application of what I have just said. Okay, in a clinical case, this is a patient who was like 63 years old. You can see the profile with the straight lips, okay, crowding, collapsed arches in the upper lower arch, and the overbite, You can also see the 42 and 32, which are tipped to the mesial. Okay, you can see the endoalveoli, like the crowd at the same time. This posterior collapse, right? And if I should look at the occlusal, then I will see much more the huge amount of crowding. We did not choose to extract the premolars, obviously, with respect to the age, with respect to the profile. You can see the ceph a little bit later. And we did not want to extract the lower incisor because I don't like lower extractions, because simply it's not indicated in this case. If you look at a little bit of the theory, at the same time, when you remove a lower incisor, you will have black triangles. Okay. So this is how the clinical case, how it was presented. Class ones from both sides. Again, it's not like something extremely difficult, but at the same time, you can look at the profile, how the profile. So if you can imagine if I extract 4 premolars, what would have happened with respect to the profile, etc. This was not at all an extraction kind of treatment plan. Now it's like this, it's finished like this. Okay, these are the steps. First step, we aligned and by that, and then we added some composite on the dentist added some composite 21. You can see the before and after on the occlusal sides. A little bit of expansion on the middle side, middle part of the arch, not on the posterior, just a little bit middle, and change the arch form. We changed completely the arch form so that it would be much more parabolic and much more beautiful, right? And obviously 2.2 millimeters floor stripping on the lower arch. It's a brightening of the premolars and the molars, a brightening without extraction, just alignment. And the use, of course, with these two principles, which are super basic, but at the same time, extremely important. First one, the use of the trigger points, it's the exact areas what we want to have, or we want to have them to be. The second thing is the control of the spaces while we are aligned. Okay, this is the before and afters. If I didn't have this control of the spaces while we are aligning this kind of arch, never I would have seen the collisions in between teeth. And I'm sure, and more sure, have been a very big user of the big brands all over my life. And I'm 100% sure that if I didn't see the collisions in between teeth while these teeth are aligning, I would have lots of collision. And this kind of treatment would have lasted much more than 18 months. Okay. If it would have been finished. Sorry. Okay, so you can see also the interincisor, the relationship between the upper and lower incisor, the profile. Of course, everything would be good. The parallelism of the roots. No one can say today that the lines do not work on the roots. They do work on the root. They do work better than braces. However, we have to acknowledge that we have to know how to move the roots in the proper conditions, in the right conditions. The softwares will not move the roots that we want to move. We have to be much more intelligent, much more aware of the biomechanics of the aligner system. Okay. This is before and afters, the interincisor angle, the profile, nothing changed. We did not retract the upper incisors, no black triangles, everything fine. It's just a brightening and then expansion a little bit of alignments. Now, one thing is that inside the system, okay, we have these kind of specialties, we have this kind of specificities, but at the same time, we have someone who's watching. That means when you send the case, especially if you are starting, even if you are a little bit expert, and you want some help, all these pre-treatment plans will pass by what we call observer. The observer is a very, very experienced clinician. It's not someone who had just made some orthodontics. Like, I mean, he went to the university and then he then changed his path and his career and he became a technician. No, he's someone who has worked lots of times in lots of clinical cases. He has lots of cases, and he's a super expert. So when you send some case, then you want something. This expert, which is an observer, which is an orthodontist, will look very minutely in all these small details so that he will deliver back something which is much more predictable, because in his mind, this clinically speaking, because he has this experience and he has the know-how, he will deliver something which would be adapt what you talked, because he will understand the terminology, he will understand your treatment plan because he's an orthodontist. But at the same time, and this is very, 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 very important and very, very, very critical, is that the technician that you are used to work with, he's not at all an orthodontist. if you give me the best technician in the world, he will still stay a technician because he did not, and he will not see the results of what you have done on any kind of case in the mouth. An orthodontist who has done this in the mouth, he knows exactly what works and what doesn't work. And eventually he will say no. He will say no, because he will say this case, we prefer that, and this is not a judgment or like you can, it's not only him, he will decide. It's not a decision that's taken by only one person, but if the orthodontist who's responsible for this treatment plan, he says, he thinks that it's something which cannot be done only by aligners, then there's a community which that would take this into consideration, and if all the team of the orthodontist around the case, around Bloom, considers that this is not a case that has to be done by aligners, then you will have a rejection. You will not have something that's moved in 3D dimension of space, and then everything is okay, and then you say, okay, and I'm the responsible because I'm the doctor, and everything else we don't care. No, we do care, because we do know that this will not work, and if it does not work, we will tell you. And if it works better with some other systems, we will tell you. If it works better with some kind of accessories, we'll not only tell you, we'll tell you, and we'll tell you how to do this. So if you need to add some brackets, either it's a lingual or buckle or something like this, if you are experienced or not, you will know this because you have a profile. And in your profile, we will know what kind of experience you have. And with respect to the experience that you have, we will treat you with respect to the experience you have. You cannot be a dentist, you understand, two canines. You cannot be a dentist and you have never done aligners before, and you send cases that you have to be surgical or something like this. Okay, and you cannot be an orthodontist and you have never done aligners, and you start just by 4 extractions. And we are aware of this because we know it doesn't work. And we will tell you eventually it works, but you have to add some accessories, and then we will discuss with you if you can do it or not. We have the courage, and we have the possibility of saying no when what is not properly done, because we really care about treatments, and we really care about the patients, and of course we really care about the results, because the results that you will have will impact on your choice and your confidence with respect to the aligners, and it will push you more and more to be a better orthodontist, aligner orthodontist with time. This is something which is very, very important to the philosophy of this system, because if it is not, you will start with some aligner for the first case, and then all of a sudden you say the aligner doesn't work. No one is hearing me? So, you're hearing me? I'm talking like crazy. Everyone, okay. Can someone give me a sign?
We can hear you. There is no problem.
Thank you very much. Okay. Okay. So because I received a small message from the systems, no one is hearing me. Oh my God, I'm talking like crazy. No one is hearing me. Okay, so this is the observer side, and this is super critical, my friends, because I have seen this every time in my life. A very experienced orthodontist who does very few clinical cases with aligners, only class 1s with the crowding, and he says, and then I have seen, like, masters, like very, very good orthodontists. They say, no way I do aligners anymore. I tried to do this. It's finished with 3 refinements, and the lower canine, it didn't tip. I had to finish with lingual just for the lower canine. Yeah, of course. And then when I look at the setup, I say, oh, it's obvious, because this has to be like this, because blah, blah, blah. Okay, it's very clear for me. It's not very obvious for him because he has never done like this before, this kind of treatment before. So we have the courage to say no. We have the courage to say we have to do this better. And eventually what we have discovered is the learning curve of the orthodontist using the system is going so very fast, because they are applying what we are telling them, and then they will learn what might work and what might not work. And in 1 year, they become from very beginners to, like, I'm not saying experts, but from very beginners to really good orthodontic aligner orthodontist, really good, really. And this compensates hugely going to a master class, taking huge amount of information for 3 days, and then all of a sudden you have to apply them all on the same kind of system, and you are the responsible of the results. Hugely it compensates. Why? Because you are having a clinical case, And if it's something is not working, then you can contact someone from the society. Look, this is not working. Let me show me. Okay, take some photos, get them back. Fine. Okay, this is what, because it has to be like this. Okay, like now you have to add some tip back. You have to add some, like, you have to add some elastics and stuff like this. So the system accompanies the doctors to improve, and when they do this kind of improvements, the learning curve goes extremely steep. Now, another thing which always got on our mind is that why do we use only one plastic for everything? Why do you use only one wire? We never used one wire for everything, You always used a very small, thin wire when you want to start, because there's less of crowding, because the pressure of these wires is very slow. Okay, it's very not very heavy. And then eventually, when the teeth are aligned, when you want to start tip and torque, then eventually we'll increase the diameter and the stiffness of this wire. So why the same plastic? It's not logical. I mean, okay, when I want to align, fine, the plastic has to be super elastic. Okay, I can understand this. Why? Because it has to fit in between the crowded teeth. And when it fits in the crowded teeth, it can push the teeth, right? And then it pushes the teeth, it can align. Okay, but after this, I have an extraction of the first premolar, and I want to push the roots at the same time. And using the same kind of plastic which aligns the teeth, it's like the super elastic 0.14 night wire, it does not push the roots, right? So why should the super elastic aligner push the roots? It will not. That's why we will have the tipping of the crowns. That's why we have, in this system, we have two kinds of plastic. Both of them are triple layer, of course. Whatever you hear, one layer, like single layer, go away. Don't use aligners that have single layer. Whatever kind of aligner you're using, whether it is a big company, small company, medium company, homemade, whatever. One layer, merci, au revoir, okay? 3 layers. Otherwise, you will understand why. So now, this system has two kinds of layers. The one which is soft, because there's 3 layers, right? Soft from the outside on both sides and hard from this inside. So when it is soft from both sides, it would be much more adaptable, and then you squeeze inside the crowding of these teeth so that it goes inside the small space and pushes the teeth. So this is good for align. But once I align the teeth, then I will have to have something a little bit more stiffer. So it would be hard, soft, hard. So it is harder on the both sides and softer from inside. So it has a little bit of the elasticity, but when I want to tip the roots of the teeth, I will have something which can tip these 3 teeth, and I will have control of the roots. And I will also have control of the torque. Okay, so if I want to have expansion, the roots are like this, I can push the torque of the teeth, posterior buccal torque, like buccal root torque of the posterior. When I want to expand, then I will use the other kind of liner, which is the triple layer, of course, the same thickness, the same kind of plastic, but the composition of the plastic will be a little bit different. Instead of being soft, hard, soft, it will be hard, soft, hard. And this would be very convenient to have these kind of movements when I want to control the root, the tip, and the torque. So this is a very nice example of a perio patient. You will see how we have combined these kinds of plastics so that we can have maximum efficiency of the system. Look how it works. So this is a case where you have like a 30-year-old woman, class 3, but class 3 compensated by the proclination of the lower incisors. Okay, you can see the perio problem. This is a really perio problem. Okay, so of course I will not compare brackets with aligners, especially with these kind of cases. It's no brainer. People who do aligners understand completely what I mean. Perio patients, you have to stick to aligners for hundreds of reasons. I will not go into details, but anyways, perio patients with aligners is a dream with respect to braces. Now, taking this into consideration, you have class 2 from one side, you have you have crossbites from the other side, and you have some spaces. Okay, and then you have some space on the lower arch, and then you can see all these perio problems that you have on the upper incisors, where you can see obviously even on the lower incisors. So what we have tried to do is just to correct the anterior occlusion, okay, correct the crossbite, closing the spaces, all the spaces, and to harmonize the upper and the lower arch so that when the patient bites, he will have a good occlusion. This is what we have done. This is what I have started with, and this is what I have done before and after. Okay, okay. Then this is what I have done as much as we can from here to here. Now we have arrived to here with the basic kind of plastic that I have told you, which is soft, hard, soft. Okay, which has been very super good, because what has happened is that it aligned the teeth, and then it pushed the upper teeth forward and the lower teeth backwards. Okay. Now we have arrived this, but the patient was not happy. Why? Because of course she told us this is not the black triangles are very anesthetic. Now, of course, we can think whatever we want. Okay, we have changed your smile, and we have it was completely difficult, but you see, already she has a peri problem here. She has peri problem here, and you have seen this in the pan. When we have closed the teeth, obviously, the dark triangle will be very prevalent. So we have tried. I have taken some courses about injection of hyaluronic acid in this papilla, but it didn't work. You can see a little bit here. It worked a little bit better from the upper arch and the upper papilla, but it did not work. So what we have tried to do eventually, I told her, okay, listen, I have seen the divergence of the lower incisors. They're a little bit divergent. They're not very straight. So we have used another refinement of the system, but without using the first set of aligners, which is soft, hard, soft. We used the hard, soft, hard. Why? Because I wanted to tip the teeth. So we have used some attachments, but we have changed composition of the plastic on the software, and then we decided to tip the teeth with some stripping and like IPR in between the 11, 30, 31, 41 to increase and to squeeze the papilla with this hard plastic. Because if it was this first plastic, which is very soft, and it would be very difficult to do this, but it is a little bit harder, and the stiffness of the plastic with the right protocol, of course, with the treatment plan, with the observance of the orthodontist, has done this result. So eventually we have moved from this to this, and then after this to this. Okay, and the patient was super happy. Of course, it was not completely closed. The triangle noir, the dark triangle, it was not completely 100% closed, but it squeezed as much as it could the papilla, and then it closed it as much as it could, and the patient was super happy with respect to it. So I wanted to show you the indication of using this kind of plastic, the stiffness of the plastic, to have better clinical result. And then we have changed completely this prescription. Why? Because the prescriptions are always copy-paste. So you have these 5 systems, the same thing. Okay, big companies first, of course, they have pushed everything forward, and they are very always recognize the power and the capacity of the biggest company in the world. You know what I'm talking about, who has pushed the boundaries and made a huge kind of improvement in this work with respect to aligners. But after this, it's copy paste, with all respect. So what we try to do is we stay in the prescription form, and we did it first. If someone is very beginner, we take complete control. We do everything that has to be done instead of the doctor, and then we try to accompany him so that the learning curve will go as high and fast as possible. Now, once the doctor is a little bit more experienced, and this is the most of the cases, because lots of doctors are doing aligners today, then we have changed the prescription form, and the prescription form has changed in different ways. So you can see we don't have enough time so that I can detail this, but it is very adapted to someone who does align. This is a distalization protocol where you can have 3 millimeters of distalization in only 30 aligners. And this is only possible because we have a certain protocol where we can distalize 6 and 7 with double elastics, one on the 6 on the lower and on the 4 on the upper, the other on the 5 on the lower, and the palatal, the third 3 on the lower, on the upper. You can see this. So 6, 5, 4, 3 from the palatal to increase the torque of the canine, and distalization only with 30 aligners. Knowing the sequential distalization, now I'm not talking about mini implants, whatever. I'm just talking comparing this distalization from one system to another. This is 30 aligners, the other one is 70 aligners. So going back, see, you will have the cuts from the canines from the palatal to increase the buccal torque. so that when the teeth are retracting and they're distalizing, then it will be much easier to distalize. And then when we want to push the mandible, it can be pushed, especially in the teens, easier to have this control of the jump. So this is 30 aligners instead of 70 aligners. And it's completely kind of different mentality. I have lots of courses about this, and we can explain this in details in other kind of. This is the case. Superior patient, class 2, division 1. And then we decided to. Right, okay. We decided to distalize 6 and 7 at the same time, and then 5, 4, and then all the block from the upper canine to canine. Okay, this start like this, and you can see all 30 aligners more or less. Okay, we have finished. Okay, the arch form, the completely is different with the lateral incisor pushed to the buccal. Okay, you can see as well the lower arch without any kind of difficulty. This is during the line, and then you can see the class 1s, what it is finished. 30 aligners. Now, 30 aligners, changing aligners every 10 days, what we recommend normally is 300 days. 300 days is like 12 months, right? A little bit more. 240 days, yeah, like maybe like 13, 14 months. Now, it's like 13, 14 months to have a 2-3 millimeters distalization instead of 70 aligners, right? So it's completely changed the way of facing things with respect to distalization, with respect. This is how we're finished. And then, of course, for more experienced doctor, we have added protocols with mini implants. Now, if you are inexperienced, anyways, when you start with the system, we will separate you if you are experienced or not. If you are not experienced, you have different kind of attitude with respect to treatment plan, and when we treat you completely differently. When you are experienced, then you have another kind of thing, and then we know that you are, and then we would try to push the boundaries together. Now, of course, when you have a class 2, division 2, something like this, and the patient doesn't want surgery, now, obviously, if I want to reduce the overbite, then I will have to put mini implants. If you are experienced, you will love this, because not only we will propose something which you have never proposed to your patient, but we will help you to accomplish it with lots of photos, lots of videos that we will send to you how to place the mini implants, why we think it's better to put the mini implants in this place, in the other place, etc., etc. And then we will elaborate together. We'll tell you how we think that digitalization, this kind of thing, work better or not. Okay, so this is a bigger case, and in the prescription form, you will just click on something. I want to treat this class 2 division 2 with mini implants. When you click on it, there is a big protocol, okay, which the technicians will have, okay, with lots of checkpoints. Okay, once they do this, they have the checkpoint done. Once it's done, then eventually the orthodontist observer, as you have listened to me, the observer would go back and then he would check again and again to be sure that all the checkpoints have been minutely, very, very precisely done by the technician, so that when it comes back to you, it will come with much more predictable things. So this is a big case, of course. We are on it still. It didn't finish yet, but I will show you the results. It's like this. You can start it like this, before and after, and you can see. Of course, it didn't happen. It's not only aligners. This is distalization and proclination at the same time. Simultaneous distalization and proclination, helped by anterior mini implants. And we will put mini implants in a certain stage that we think it's better, and we'll tell you which stage. Okay, so that you will not do this because you don't know it, how to do it. No, it's like thinking together at how to put this in a better way. Okay, so it's like proclination with mini implants and distalization, derotation at the same time. Once there's the proclination, then we will drag and through them, and the lingual would talk as you know. This is how it is today. You can see the mini implants, how they are, etc., etc., and you can see the huge difference of the distalization, the proclination, and the anterior only just with the aligners and mini implants without any kind. And you can see the results. You can see how we have also, of course, we have treated this patient with the upper intrusion because she did not come for the gummy smile, but because we know that we can do better, we know that we can perform better. So we will go to the maximum because we want the best for our patients, of course. Now, another kind of case, I will not go into lots of details on this case, just to give you the potential, the huge potential of the aligners that we have today, and how can we change completely the lives of the patient, not only just aligning some teeth and just some crowding and sterilization. No, we can have things like this. This patient came from another clinic with a huge open bite, and then we treated her with different steps. Of course, it did not start. This took 2 years. It was expansion and posterior intrusion with lots of posterior mini implants, and then a derotation and closure of the bite with the posterior intrusion. So you can see how she came. She came like this, completely open bite. She just touched on the 7th posteriorly, and she finished like this. First, you can see the mini implants on both sides, the anterior elastics on the 3, 4, the canines and the premolars, and eventually the anterior. So it was, you have always to consider this posterior intrusion and then anterior extrusion at the same time. Works very well. So you have a hinge axis. When I concentrate on a point where I don't move teeth and then I intrude and extrude at the same time, it's much better than I just intrude from one side and then the other side just floats. Okay, just one point where I just fix it and then I intrude and extrude from one side and the other side. This was the main principle. Okay, you can see before and afters, before and afters, before and afters. Right. The expertise of the orthodontist behind will help you hugely to perform better. The obsession of the system is to have 2 things: to have results with minimum number of refinements, and if there is a refinement, it has to be the shortest refinement possible. That's the first thing. The second thing is the super satisfaction of the patient, eventually the doctor. These are really the vision. The vision of the company goes like this: whatever we do, we try to perform as best as we can, so that the orthodontist would say it works. And when it works, he by himself, he will be a better prescriber, and he will by himself increase the number of patients who have aligners in his clinic by himself. So you can see before and afters. You can see the smile. It was more posterior intrusion than anterior extrusion, because we did not extrude the anteriors. Because of the gummy smile, you can see all this. You can also see the closure of the bite and the lateral ceph. Okay, and this is something that this is a long story. This patient had you can see a huge open bite, hyperdivergent, surgical 100% case. I present this sometimes. The surgeons you just look at me as if I'm crazy. And it's like, of course, thumb sucking. So we put an antipus to the appliance first, so that you can stop the thumb sucking, expand, and first of all, stop the thumb, then posterior mini implants, posterior intrusion. First of all, expansion, of course. Once there's the expansion, then posterior intrusion, anterior extrusion with lots of attachments here. But however, extrusion of teeth, we cannot put pressure points. It doesn't work for the moment. Trying to invade in this, but for the moment, it doesn't work. So attachments on the anteriors to extrude the posterior teeth, and mini implants posterior to intrude the posterior teeth. And then it started like this. You can see how far we can go with these 3 implants, how far we can achieve with this simple tool, which is called aligner. Why? Because we have to understand how it works. Okay, and when we start, we don't know how it works, and then we have made hundreds of mistakes. I have made hundreds of mistakes in order to achieve this. I've been to thousands of places. I don't know how many webinars I have seen in my life and how many master classes in order to perform like this. But this is something which is very important, because the orthodontist today has these kind of cases. The adult patient comes today, he wants aligners. If you want to put in braids, he will go to somewhere else. If you want it or you don't want it. If you understand or you don't understand it. Especially in big cities, especially in Greece. Okay, if you don't have any choice, you have to adapt yourself in order to treat the patient with aligner. Otherwise, he will go to the competition. Believe me or not. Okay, so we are like this. It has class 2 from this side, class 1 from the other side, class 2. So the power and which is huge about the aligner. I can sterilize from one side. I can meserize from the other side. I do whatever I want. It's a system that I can perform when I understand the biomechanics of it. And look at the huge open bite with the hyperdivergence of this patient. But even though we changed completely, so we're like this, and this second stage, third stage, and we are like this. You can see the mini implants posteriorly, it didn't finish yet, but we are trying to finish, and soon I will finish it. It's not very far from the finish, and you can see the evolutions. You can see how what we did with the arch. This is really a life changer. Okay, this is really a life changer. The patient now. You can tell me the tongue, whatever you want to. Yeah, I know. Okay, but I have, but I can. But when the patient is very aware of what you have done to her, and then you to tell her, okay, you have to do this, and you have to go to the specialist for the tongue, and she will go because you have changed completely how she looks like. You have changed completely how she eats, how she swallows, how she does everything. And you know more better than me that the mouth is not only the teeth, it's also the digestive system. The digestive system starts by the mouth, and the digestive system is life. So you can see before and afters, and look at the change of the ceph. Okay, the orthodontists who are there behind the screen, look at the change of the ceph. Okay, what we have done is really we have completely changed the occlusion. We have completely derotated the mandible only with aligners and mini implants. Only with aligners and mini implants. Okay. Of course, everything is made in France. It is the boxes are very, very sweet. We have lots of kind of recommendations about this. And then I will finish in 5 more minutes to introduce you things that are proper to the system, are a little bit different from others. It's not a copy-paste system as you have understood. It has lots of inner thoughts, and at the same time, the people behind it are trying always to push forward. So one of the things that you can order as well, white aligners. Now, white is not very white. It's not like chalky white. Okay, they are very good. I mean, when you put the white aligners on the teeth, they can align teeth at the same time they are white. So the patient has the impression that he has already whitened his teeth. There are two kinds of consequences of this. First of all, the compliance will increase because when you put aligners that are white, you cannot the next day change them and they become less white or transparent because you have already white teeth with respect to the people that are seeing you. And the second thing is that when you have missing teeth, when you have a white aligner, then the missing tooth will not be visible. If you have lateral inside that's missing with a white aligner, it will be completely camouflage space. If you have an extracted premolar, it's the same. These white aligners have seen increasingly kind of success with respect to the aligners, with respect to the bloom, because they are demanded more and more, because they are aligning and at the same time they are whitening. They are not really whitening, but they are white, so the patient thinks that they are whitening. Another thing, this is already launched, and this has been already launched like 3 weeks ago, or 1 month, something like this. It's what we call the dummy aligner. Now you can order when you start a case, starting from the second day. So if I started the case today, to tomorrow, really tomorrow, I send the case to the platform, where everything is done by platform. Okay, tomorrow I will receive my first aligner on a setup, my first STL file. So I sent the case today. In 24 hours, I will receive the first STL file, which is the état brut, which is the real, like the first step. I will have it on the platform on the patient's name. Eventually, as a doctor, I can do two things with this. I can either download the STL file and print the first aligner because I have a printer, or I don't have a printer, I have a lab. And then I will send this by email to my lab, and he will do the first and send it back to me. The objective of this was to make things super fast. So if I have a patient, instead of making him wait 2, 3, 4 weeks, so that the aligner will come to my clinic because they have to do the setup, to accept the setup, to fabricate the aligners, etc., and all the transportation kind of thing. Now I can, by starting from the first day, send this prescription. Tomorrow I will receive the STL files. If I have a printer, I print the first line and give it to the patient. If I don't have a printer, I send it by email to my lab and our partners, the partners of Bloom in Greece, Bulgaria, and Cyprus, and in lots of countries. It's because I'm talking with respect to these countries, especially in Greece. I will show you our distributors in Greece by the end of this presentation. They can also help to fabricate the first aligner. So the second day, you will have your patient having the first aligner without attachment, without nothing, but you will tell him, listen, look at how fast we are, so that he will have the first aligner by the second day. So this already exists. Another like small differences when you have, so how many times I'm in my clinic and then all of a sudden I have to remember, or I have to look at the stripping sheet or the setup that on this stage, on aligner number 15, I have to do stripping. Okay, I have to do IPR. So these kind of small kind of things, sometimes we don't pay attention, especially if we have big clinics, we have assistants that help us. So IPR, we do this in stages, and sometimes we don't pay attention. So we have adapted these kind of small colors. Blue means that you have to put elastics on this stage. So we'll accompany you. We'll tell you exactly which type of elastic that you have to put and which stage. So blue means you put this elastic stay. If it is like aligner number 15, then you will have to, so you see on the back, blue, then you will put the elastic on aligner number 15. Red means something much more important, so it's either IPR or attachment. So if we have to do IPR in different stages, on every time you have to add the IPR, you'll have a red flag, red point on the aligner back, so that you will not miss the IPR that you have to beat, that has to be done. And this will come very, very soon. These are the new things that will come. Now, it is all the time trying to accompany the orthodontist or the dentist, the practitioner, to do better things. So you will have a small video with the head of the practitioner, the orthodontist, that surveyed your treatment plan. So on the screen, you will have small video. Click on it, and you say, and it talks to you first with your language, not Greece. I don't want to promise the things, not Greek language. No, at least for the time being, Spanish, English, and French. And it will speak to you in the language, English, for example, tells you, listen, this is the case. We had to do some IPR here because like this. We had a jump by the end of it because of this. We recommend to put some. It's a recommendation, of course, because, etc., etc. So it's not only we will promise that someone will look at the treatment plan, but also we will deliver a video that will help you understand why it has been done, and it will elaborate more on the treatment plan and all the tricks and small details that you have to pay attention to. Starter kit, it is something that will be sorted like in September. When you are a dentist or an orthodontist, you want to start all the time, you have this kind of questions. Which composite I have to use, which stripping I have to use, which IPR, which cutting mesh, which cutter I have to use. So you will receive for the first case a starter kit. Everything is inside. You will have the bonding, you have the composite, you have to everything inside in a small kit, so that you can open it. And I'm ready to start by my aligner case. I have never done aligners before. I have everything here. I don't have to search from my drawer to put something which work less effectively, of course. Because if you're using composite on a dentin, it's not the same thing like bonding upon composite on an enamel, etc., etc. So I have this starter kit, open it, and then you have some small also QR codes. You can flash them, and you have videos of these QR codes of how to use this and why they are there and for what reason. And the Bloom store. So all the things that you are used to do, like buttons, elastics, cutters, whatever, everything which is related to the aligner world, it will be collectively focused and on the same platform. So you can order the aligners, of course. You can go there and go and choose the buttons or the tubes or the cutters or whatever, which is, or even the composite from the store, and then you can order them. Or if you want to just have them, and they can order them from wherever you want. The objective is to focalize everything so that the questions come and they do not come back the same, and to use things that work. And then, of course, most importantly, it will be exclusive to the Bloom users, and the Bloom users will have huge kind of prices on these things that you never, than anyone in orthodontist will never have from any kind of provider, just for the users of the system. All right. Now I will finish in 3 QR codes. Hopefully that you are looking at this from my PC. Okay, the first one is my Instagram. Okay, of course, just to see what I'm doing, and then I will follow you back. The second one, it's very interesting, and this is a group, WhatsApp group, where for the moment it has 850 or something users. And this group, we We share our experiences, we share tips and tricks and lots of clinical cases. These are only orthodontists and more or less experienced. And you will learn lots of things, not only with respect to Bloom. I mean, everything which is related around the world. We're really like 850 people for the moment. So do not hesitate to add yourself to this group. It's very, very, very educational, really. And then you can use whatever we put in any kind of aligner system that you want, of course. It's really done to connect orthodontists from around the world. It's going increasingly very popular, and we have lots of doctors coming from all over the world and they add themselves to this group. And believe me, everyone can post. It's very monitored, of course, and you can learn huge amount of things on your phone every 2-3 days. We post like 2 or 3 times per week, and many people post more and more, and they ask questions, etc., etc. And then this is our distributor in Greece today. This distributor of Bloom. It's Cardio Dental. You have all the connections, everything that you need. Dr. Daffy and his team that we have known for a long time, super professional people, very, very serious people, and very, 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 very professional. And so if you have any questions, if you want to try something, try some case, please refer to Cardio Dental, and you have all the coordinates. We have great pleasure to work together in the future. And finally, these are my coordinates. Okay, I have put even my WhatsApp, don't hesitate. My email. If you want to come to see the clinic one day, it'll be really a very, very good pleasure. And hopefully see you soon. Thank you.
Thank you very much. Thank you. Everything was really, really nice.
You remind me very much. Once I gave a lecture about oral photography, and my wife saw it and said it was fantastic. I didn't understand anything, but it was very, very nice. It was wonderful, but
Yes, in fact.
no idea. But very nice.
You're a dentist?
Yes.
Yeah.
Okay. Well, yeah.
No.
Well, sorry. Yeah, it's a little bit more. I mean, the Bloom is well, of course, when I'm presenting, I try to be as much. I try to bring the level a little bit high, but for practitioners who don't do, we monitor them. So if some things are difficult, we say, listen, this is not something for you. It's better to send to the orthodontist, especially children. So we have this philosophy that if a dentist sends children, unless it's really, really very easy, because the responsibility, we say, please listen, this is something that is very important. As a child, growing child, it's better to send to orthodontist. Doesn't mean that you cannot do things. Adults, of course, there are lots of adults that come to your clinics and they have some crowded teeth and stuff like this, and it's super easy today, and it has to be done. Okay, because if the dentist doesn't do it, no one will do it, and the patient will stay like this. He doesn't even know that it's possible.
That's correct.
Sure.
Totally agree. So there is a question. A friend from here they asks for the case with the lateral incisor. You did IPR in order to make source to put the lateral in place, to make space to push the lateral in place.
I will try to explain. I always work with my hands. Now, IPR is one of the solutions, and this is bad because there are lots of systems. When you have crowding, just put IPR. But I mean, we don't need IPR. We use IPR when there is no other mean. When I finish all my possibilities to do things, then I will do IPR. It's not the first intention. Because when you do IPR, it's okay, it's easy because you find places, but at the same time, IPR is not it's not a piece, it's not a joke, because you will create problems in the future. You know this very well, especially if the IPR is not 100% done well. So what we have done here is that we have, this is the treatment plan, how we do this with the orthodontist. So the lateral incisors were like this, okay? What you have done is that we have pushed the teeth a little bit, expanded, and then pushed the lateral incisor a little bit buccal, a little bit. Why? Because I want to have pressure points, the trigger points. So 1 millimeter buccal, I have the captivation of the mesial and the distal of this lateral tooth. I will tip it with the pressure points, with the trigger points. Once it's tipped, then the expansion, little expansion posteriorly, I have fine spaces, then I will put it back. Fact that the lateral incisor is tipped like this, it occupies much more space when it is right, because it's tipped, right? This is much more space. So what I've done is that I pushed it, I tipped it, expanded posteriorly, and came back, 0 IPR.
Fantastic. But I understood half of what you said. I'm an endodontist, so I understand very little about this. But I see how you're able to transform the position of the teeth like this, and this is really amazing. It's great to know that there are sometimes treatments to just straighten or bring back a function in mouths that are really dysfunctional, like the ones that you showed us. So I totally appreciate what you're doing and what you show us. Nicholas, thank you very much. No, there are more questions. Thank you very much for the lovely presentation. Can we treat a patient who already has 1 or 2 implants?
Well, that depends. Of course, the implants, you cannot move it. So we have to see the treatment plan, how it works with respect to the, for instance, if I want to expand and I have an implant on the arch that I want to expand, it's a problem because the side where I'm expanding, I cannot move the teeth. But I have to find other solutions. So maybe I do not expand, maybe I do something others. Now the IPR becomes more favorable as a solution because of a blockage in one way where I cannot find space for the teeth. It's possible, it depends on the clinical case. And when you send cases, then we will analyze this, and then we will tell you what's the best solution in our eyes to treat this kind of patient. And if there is no solution than IPR, then we will say, okay, the only solution that we have is IPR. But all the time we keep IPR as the last solution possible. Okay, unless we don't have anything else. But implants is one of the things that obliges us to do IPR.
Super. Thank you very much.
Just, could I ask you something, Nicola?
Sure.
I would like, because it's about general dentist. Usually they do orthodontic before a prosthetic treatment plan. That in that case, what do? You ask the treatment plan, you ask a smile design, you ask, what do you ask? Because sometimes it is different, usually the orthodontic close spaces until the teeth touch each other. But we sometimes we need to leave spaces in order to make the teeth larger, for example, the central incisors, because it is the right dimension upon the length. In that case, what do you ask? You ask how much do I have to move it, or you ask the plan, or they usually they say put this tooth in that point. What happens? Sorry.
Okay. No, okay. So actually, when you have to send the photos and the scans or the impressions through a platform. So when you send this through a platform, the platform will ask you things that you have to fill. So, for example, for example, what's your treatment plan? Or do you want to close all the spaces or open the spaces? Or you want to open the spaces to put an implant? Or you want to redistribute the spaces to make veneers? So the platform by itself, if you are a dentist, will ask you proper questions. First, this is the first thing. When these questions are being asked and you reply, and it's just like clicking, click, 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 then we will have a kind of global view of what you are asking for. Okay, we'll understand what you want, but we will help you on these kinds of questions. We will ask you these questions, so it will be easier for you to answer things other than just telling us what you want to do. And by the end, you have a paragraph, you can write whatever you want. You can write like pages, whatever you want. So that from the other side, when we see the orthodontist from the team, when they see the trip, when you are what you are asking for, then we will see, okay, she wants to do this and this and that. She wants to leave the space for the implant, or she opens the space for this because she wants to do an implant. Okay. And then they will do the treatment plan or the 3D with respect with what you have asked or you have filled. You will see it, then you can refuse it. Okay. It's not something that's like sacred coming from God. No. We send you a proposition and then say, okay, it's good for me, or no, I want something else. So you can say, no, I'd like to do this and this and that. It comes back to us, and then we change again. We send it to you. And if for you it's convenient for you, then you will accept it, and then it goes. Then the runners are made.
Sorry. This is perfect. It means that you do most of the treatment plan. So, and you do the plan almost.
Yes, of course. That's why we categorize doctors. So the doctors who are like dentists are some, and then orthodontists are another place. We categorize them, and then we see how experienced they are, and with respect to their experience, the platforms are different. If you are a dentist and you never done aligners, your platform is completely different than our dentist that has made aligners. It's completely different. We will not talk with you in difficult words or like difficult dilemmas.
Exactly. Or terminology of orthodontic. Yeah, that's true. Yeah.
That's what I've understood when I finished that. It was good, but we didn't understand lots of things. I understand. Yeah, but yeah, it's obvious when you tell me some things about implants, I will not understand quite well. The same thing for you, but that's how we adapt the terminology, and also we adapt the expectations of the treatment plans. So if you are a dentist, then we will tell you this is not possible. Okay, don't do this. Send it to the orthodontist. It is possible. Okay, we said we will do this and this and this, so that you will have the least kind of intervention possible. So you will not have problems. This is the main point.
That is exactly the most important.
Yeah.
Because sometimes they do orthodontic and finally we don't arrive to the result that we need.
Yes, well, we try to minimize this as much as we can because we know it, because we know this. It happened with lots of systems before. And no, this is the thing, is that it's not because you are the responsible and because you just click on accept, that means you are allowed to do everything and all of a sudden you have problems and nothing is solved. This is not the point. Otherwise, our lives would be not, I mean, no one will do aligners anymore, really. Okay, it has to work.
Yeah.
Perfect. And we have another question.
Okay.
What about younger patients? Do you place the retainer wire to all patients? For how long? Can we use the intrusion for periodontal teeth also? Does it work? I think it's more than one question.
Okay, so one by one. Younger patients, we can do everything. I mean, it's even easier because the bone is much more flexible. There's no limit for this. The only thing is that the younger patients have erupted teeth. So when teeth are erupting, then they will interfere with the aligner, and then it might cause some problems. So you have sometimes you do 2 or 3 impressions, scans during the treatment. This is the only thing with respect to the younger patients. I have patients that I start from 8, 7, 8. Okay, because I want expansion, lots of alveolar expansion or alignment, distalization, the rotation, things like this. There's no limit with respect to the age, whether it's like young or old. The oldest patients, in my clinic had 84 years old. Teeth, you can always move them. Now, they move less when the patient is older. So you have to take this into consideration. And this is easy with the softwares because you just adapt the velocity, the speed of the aligners, how they move with respect to the software. So it's very easy to be done. Now, with respect to the perio, yeah, what I've said is, I said this very fast, is that the advantage of having aligners is that you can move teeth whenever you want to. So should I have this 31 or 41, which is moving because there's less of the bone around it, then I will say this tooth, you don't move it first, or move the root first, or like decrease the intensity of the force on this tooth so that it will move slowlier. And when it moves slowlier, then it will have less problems. So these kinds of because it's a computer, you know, it's a computer. So you can tell the computer whatever you want, and the forces they differ from what you ask. It's not like bending wires. It's not dependent on the operator. It's depending on what you say to the computer.
Oh, Nicola, thank you very, very much. I have no words to thank you. Everything was amazing.
Really appreciate it.
Hope to see you soon and hear you soon in another webinar. Thank you very, very much for being here with us today.
Thank you for having me, and thank you for everyone staying this late. I've seen that almost everyone was there. I captured your attention, and I hope that I've taught you things, and see you very soon.
Perfect. Thank you very much. Nicola, keep in touch. Have a nice evening.
Bye.
Καλό βράδυ σε όλους.